In this section, we are going to discuss on one important metabolic disorder which is not at all common in Indians for a change. It's very, very common in white population, and that is cystic fibrosis, which is written on the board already. There are two disorders which are very, very rare in India, which are very common in whites. One is cystic fibrosis and second is hereditary hemochromatosis. Cystic fibrosis is considered to be the second most common hereditary metabolic disorder in whites, typically in non-Hispanic whites, which means the whites whose origin is not from the Spain and near the Spain area. Those are called non-Hispanic whites, typically the Caucasian race, and is the second most common hereditary metabolic disorder. But the most common hereditary metabolic disorder in whites is going to be hereditary hemochromatosis. As I told you, both these disorders are very, very rare in India. And this hereditary hemochromatosis in particular, I have not even seen a single family with that mutation in India. Even if they have that mutation, they should have some origin from the Anglo-Indian race or somewhere in the Caucasian race. They should have their origin back to there. Otherwise, it's not possible. Even if you prove a single case of hereditary hemochromatosis in India, either you are bluffing or it's a miracle. And you have to prove the origin from Caucasian race, definitely. Otherwise, nobody will believe that your patient is having hereditary hemochromatosis, such a rare disease and in India. And definitely you're not going to see that mutation because it's not endemic in India. The C282Y and H63D mutations is not at all possible in India, as far as I know. But let us move on to the cystic fibrosis part. Clear? So, cystic fibrosis wise, the most important things that you have to know is the pathophysiology. So, what is going to be the pathophysiology? Pathophysiology of cystic fibrosis is on the CFTR protein, that is cystic fibrosis transmembrane regulator protein. Let us see how this protein works. So, let us assume this is a CFTR protein, and the CFTR is very important for exocrine secretory glands. Exocrine secretory glands, where in the presence of cyclic AMP, they are going to cause chloride efflux. They are going to cause chloride movement out of the cell. For secretory glands, this is very important because this chloride takes a bit of sodium along with that. Let us put in black. This chloride is the one that takes the sodium along with that. Even though you have the sodium channels, but you should have this negative potential here to take the positive sodium ions outside. So, you know where there is sodium, it's also going to rip out water along with that. So, this movement of chloride coupled with sodium, coupled with water, all these things is the one that makes your secretions a little bit watery and less viscous so that it doesn't get obstructed in that area. So, the problem with cystic fibrosis is the CFTR gene. A lot of mutations are there in the CFTR gene, and that will result in a defective CFTR protein. Either the defect could be in the synthesis, where there will be reduced synthesis of cystic fibrosis transmembrane regulator protein, or it could be due to defective transport of this protein into the cell surface, or the protein can be destroyed too much because of some mutations, misfolding, protein can be destroyed too much within the cell. In that, the transport part is the most common, where the cystic fibrosis transmembrane regulator protein will be synthesized, okay, but the transport to the cell surface will be reduced. So that mutation we'll discuss. That's the most common type of mutation that affects the CFTR protein. Let us see now what will happen. Suppose if you have poor functioning of the CFTR protein, your chloride efflux is not going to happen. Because of that, the sodium efflux is also not going to happen. Because of that, water also is not going to move into the secretions. Which means when you don't have sodium, when you don't have water into the secretions are going to become extremely viscous and very, very thick secretions, and they're not going to have sodium and chloride at all, and water also with them, because water always moves by osmosis. Here you cannot have that water, so secretions will become very thick and viscous, and they will obstruct the ducts. This secretions are going to be secreted into the ducts, isn't it? So these are the ducts, and these ducts will have this very, very thick viscous secretions, and that will obstruct these ducts, and they will result in a lot of complications. So in what way? So first, the duct obstruction will prevent any further secretion because the duct will be loaded with this thick and viscous secretions which cannot be passed out at all. At the same time, that will result in bacterial colonization because these secretions which are less in water and ions again become a very important nidus for this bacterial colonization and infection. Once they go for infection, you're going to get a lot of inflammatory infiltrate. Inflammatory cells are going to come into that area and they're going to generate a local inflammation. And this inflammation is going to damage this organs itself in the first place. This is what the exact pathophysiology of cystic fibrosis. But in sweat glands, something different happens. In sweat glands, what is going to happen is the poor reabsorption of this chloride and sodium. Because the sweat glands, CFTR's main function is to reabsorb the sodium and chloride. If you take these are the sweat pores, and you have the skin over here, and these sweat pores are going to secrete sodium as well as chloride. This secreted sodium and chloride into the skin through sweat, and this sodium and chloride will be reabsorbed back into the cell through CFTR only. So let us assume this is the chloride and this is the sodium, and this chloride is actually reabsorbed here typically through the CFTR protein only. Since CFTR is defective here, you cannot reabsorb sodium also, which means you are going to result in a lot of sodium and chloride in the sweat, which cannot be reabsorbed. So you are going to result in typical clinical feature of salt frosting. A lot of salt will be there on the skin of these patients, and that is also one of the main reasons of one important testing called sweat chloride test, where sweat chloride levels will be more than 60 in the sweat that you are going to measure. So something you have to understand. Let us move on. So these are the pathophysiology of cystic fibrosis. Once you finish off this, let us see what is the most common mutation. This most common mutation is called F508 mutation, or otherwise referred to as something called a delta F508 mutation, which means a change where the 508th position in the protein, you will get phenylalanine. That's what we mean by F. Phenylalanine. Clear? And this mutation makes this protein unstable and makes this protein misfolded. This misfolded protein will have less trafficking towards the cell surface, which means you are going to cause reduced movement of this CFTR to cell surface, which means CFTR will stay within the cell and it will be degraded over time. It's not even going to the cell surface. This is the thing that is going to be caused by this particular mutation. And remember, this is the most common mutation, happens in almost 70% of the patients. That is F508 or delta F508 mutations, most common mutation, 70% of the cases. But there are over 2000 mutations which have been proved to be present in a cystic fibrosis patient, 2000 plus mutations, but this is the most common, 70% of the cases. Clear? So what are all going to be the clinical features of cystic fibrosis? Clinical features, number one, the GI symptoms is the one that tends to start with. Typically it starts in the infancy itself, and even at childbirth you can see, typically in the form of meconium ileus. Second one, you can see something called a failure to thrive because of exocrine insufficiency. Pancreatic disease, very, very common entity. Typically they come with pancreatitis, tends to be very, very chronic. Again, because of these pancreatic enzymes cannot be secreted and the duct will block, and the duct obstruction will result in backleak of these pancreatic enzymes, and pancreatic enzymes staying within the cell and the pancreas means they are going to destroy and autolyze the pancreas, resulting in pancreatitis. That's it. Then you can get, because of the chronic pancreatitis, you will result in exocrine pancreatic insufficiency, which might itself lead to steatoria and fat malabsorption. Then you can also develop this cystic fibrosis related diabetes mellitus. Typically, this cystic fibrosis related diabetes mellitus happens after puberty, very commonly. Clear? So this is a very, very important thing again. So these are some of the GI implications, gastrointestinal implications of cystic fibrosis, of which the most important is the meconium ileus part. Clear? What do you mean by meconium ileus? Meconium ileus means if the fetus, not the fetus, if the newborn doesn't pass the meconium in 24 to 48 hours. If the newborn doesn't pass the meconium in 24 to 48 hours, this is what we call as a meconium ileus. And typically they present with an intestinal obstruction. That's how they come with. Second point to notice, they're going to present with intestinal obstruction. And what are the things they're going to have? The obstruction will be at the distal small intestine. Distal small intestine will be the area of obstruction, which means there will be dilation of small intestine because the obstruction is at distal small intestine, and there will be microcolon because the stools have not passed into the colon. The colon will be small and it will result in something called a microcolon. Remember, in white population, more than 90% of the case of meconium ileus is due to cystic fibrosis, which means almost every single case in West, if you see meconium ileus, that is due to cystic fibrosis only. At the same time, in X-ray, you might see these signs. Obviously, dilation of small intestine along with this microcolon you can see, but a very important sign called as Neuhauser sign you might see in the X-ray. What do you mean by Neuhauser sign? Typically, you see this sign in the right lower quadrant. Clear? You will see in the right lower quadrant of the abdomen, where somewhere here, where you will have this kind of soap bubbles, bubbly like appearance. Why you get this soap bubbles is due to the fact that there will be air particles, there will be this bubbles are air and the surrounding is meconium. The meconium will be there and air will be like bubbles. So this is what you call as a typical soap bubble like appearance. That is what we refer to as a Neuhauser sign of meconium ileus. And typically it's very rare to see air fluid levels because meconium is very thick to produce a fluidic appearance. So it's very rare to produce air fluid level. So you don't get air fluid levels in meconium ileus, especially if it's due to cystic fibrosis. Clear? So treatment wise, meconium ileus, even you might need a surgery also. That is different depending on the severity. In many cases, the enema itself will cure where you can somehow push the meconium out. But in some cases, you might even need a surgery if there is an ulcerated perforation or prolonged ileus, or if the intestine goes for gangrene or severe obstruction, you might need a surgery for the newborn. Anyways, these are some of the important points that you have to know about the cystic fibrosis. And pancreatic disease, typically insufficiency is the most important thing that also causes short stature and a lot of other problems. Malabsorption will result in micronutrient and macronutrient abnormalities also. So they'll have a lot of deficiencies as well. So you can correct those things. Along with that, you can supplement the pancreatic enzymes also. So these are some of the important things that you have to. Let us see one image in these patients. So the image is on Neuhauser sign. You can see this yourself, where you can see this typical soap bubble appearance. This is the right lower quadrant, as what I told you before. And these are the typical bubble-like appearance on the background of meconium you can see. This is the meconium you are seeing. On the background of that meconium, you can see this air bubbles locked in. That is what we call it as a Neuhauser sign. Very important. Apart from that, what are the other abnormalities you can get? You can get this liver and biliary tract abnormalities or bile duct abnormalities like cholestasis, cholelithiasis, cholecystolithiasis. And this cholestasis, especially if it's chronic, can lead to biliary cirrhosis. Cholestasis leading to biliary cirrhosis is secondary biliary cirrhosis usually. So anyway, they can go for this biliary cirrhosis. And they will also get one peculiar problem in cystic fibrosis patient, that is called fatty metamorphosis of liver, which means the entire liver will be transformed to fatty tissue. Fatty metamorphosis of liver. Both diseases can cause cirrhosis and both can result in portal hypertension, and because of that they go for liver failure and death. Very highly likely. At the same time, they can go for intestinal obstruction later in life, apart from the meconium ileus. and they can also result in a rectal prolapse. Even though this rectal prolapse is supposed to be one of the very rare entities in cystic fibrosis, this is actually asked in my MLE exam. When I was writing MLE, it was one of the very important questions for me, this rectal prolapse. But it's quite rare. Incidence is only 3 to 4% and less than that in certain populations, according to some studies. But since it's a question, I'm telling. Then you have some respiratory issues. Typically, they are going to show obstructive lung disease in spirometry. A lot of reasons for this obstructive lung disease. This mucus impaction, because of that causing bronchospasm. And later on, they will go for colonization various organisms. These organisms itself will cause reactive airway constriction, bronchospasm, and because of that, they go for this obstructive lung disease pattern. 4 classic OLDs, as far as pulmonology is concerned, spirometry is concerned, is COPD, bronchial asthma, bronchiectasis, and cystic fibrosis. These are the stereotypical classic obstructive lung disease according to pulmonary medicine. They can result in chronic sinusitis, which can be polypoidal type of sinusitis. They can develop polyps also. And they can also result in bronchiectasis. It's a well-known fact. Bronchiectasis is such a common entity in cystic fibrosis. And majority of the times, this bronchiectasis further, like organism colonization and further infections and finally, like respiratory failure is the usual course of how these patients die in cystic fibrosis. So this is a very important entity, bronchiectasis. And often they'll go for colonization with some organism because the organism tends to thrive in the secretions that are thick and accumulated in that area. So they'll go for colonizations. The earliest colonization, if they ask you, that is Staphylococcus aureus. That happens in the infancy and the childhood. Then later on, they get colonized with Pseudomonas. This is the most common organism to colonize a cystic fibrosis lung, and cystic fibrosis patients are abnormally susceptible to the Pseudomonas, especially because there is so much of secretions. Pseudomonas loves these secretions, that's why. And third, you can have very dangerous organisms like Burkholderia capacia complex. We have discussed in bronchiectasis chapter itself. Especially this Burkholderia capacia, once it comes, it's very, 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 very resistant organism and very notorious organism to cause death. Whenever the moment you diagnose Burkholderia, there will be a downward course in these patients, and the patients generally tend to die because it's very resistant and difficult to clear also. They can cause sepsis. Because of sepsis, you might get infective endocarditis, renal abscess. A lot of cases we have seen in different variety because of this Burkholderia capacia infection of the lung. Not only in cystic fibrosis, in other bronchiectasis patients also. It's quite like resistant. I don't know how to explain. It's very difficult to eradicate this organism. Pseudomonas is also very difficult, but Burkholderia capacia have worse prognosis compared to Pseudomonas. At the same time, the moment you see Burkholderia capacia complex in the lung, that also becomes a contraindication for lung transplantation, in fact, which means the patient is definitely going to have a downward course and there is no point in doing a lung transplantation. Presence of BCC in the lung is a contraindication for doing a lung transplantation, which you have to know it again. There are a lot of other organisms also you can see, like non-tuberculous mycobacterial colonization, Haemophilus influenza colonization, and one more worst organism, that is Stenotrophomonas maltophilia. Then Acinetobacter, Aspergillus, and again ABPA is very common. I didn't write that. And again ABPA is very common in these patients. Allergic bronchopulmonary aspergillosis. We saw that in the ABPA chapter itself. Aspergillus chapter, we have seen very clearly, like 2 patients are at very high risk. One is asthma patients and cystic fibrosis patients. So don't forget that. So these are some of the important respiratory implications of cystic fibrosis. Then you have implications of skin and the sweat glands. Typically, I told you here the CFTR is important for reabsorbing this chloride and sodium. So the chloride and sodium will be excessively present in the sweat, resulting in typically salty frosting in these patients. Plus or minus hyperhidrosis because of very high levels of sodium and chloride in the sweat. Here the little bit different mechanism I explained you already. Then urogenital problems. Number 1, we'll see urinary problems. Urinary problems, they can get nephrolithiasis. Often if they ask you what is the most common type of stone you will get in cystic fibrosis, again it's oxalate stone. If they ask you the reason, what is the reason for getting this oxalate stones, you have to answer it is malabsorption causing oxalate stones in the kidney. Remember, any malabsorption, especially your fat malabsorption, will result in oxalate stone. Because we will discuss anyway this mechanism in GIT, your gastrointestinal chapter again and nephrology chapter again, where fat malabsorption will chelate a lot of calcium. So example, if you have calcium molecules and you have oxalate molecules, generally this calcium is the one that chelates the oxalate molecules and reduces the oxalate reabsorption back. But what will happen is this fat likes this calcium, and fat now is going to complex with all the calcium and going to swallow all this calcium by saponification reaction and leaving a lot of free oxalate free in the intestine, which will be reabsorbed, causing hyperoxalemia, resulting in hyperoxaluria, causing more and more oxalate in the urine, causing oxalate stones. So malabsorption is the main reason for getting nephrolithiasis here. Then they can get frequent urinary tract infection also, which is quite non-specific. You won't be getting in exams. And genital problems, typically they will result in infertility, both males and the females. But in males, the reasons are clear-cut. In the females, we don't know the reason. A lot of poorly known reasons are there. For example, very thick mucus in the cervical secretions. Very thick mucus in the cervix may prevent the sperm penetration. So probably one reason. Second reason, because a lot of these patients have menstrual abnormalities also. Probably because of that. But anyway, this is what I feel is the most important reason why they get infertility. Apart from that, males, we have a clear-cut reason. In males, many patients will have obstructive azoospermia. That is because the secretions are very thick. The vas deferens, if it's present, is going to get obstructed and sperm is not going to come out at all. Because it's thick secretions, the semen obstructing the entire male, genital tract. Second is going to be absent vas. And certain textbooks do give this absent vas deferens is supposed to be the most common reason for infertility in males. And yes, that's true, absent vas. And probably next is undescended testis. This could be the reasons for infertility. And both males as well as females will have delayed sexual development also. That's also an important point. And again, a lot of endocrine problems also happen in cystic fibrosis patients. That is the reason. But anyway, both males and females are going to have delayed sexual development and delayed puberty. And musculoskeletal involvement. And musculoskeletal involvement is often secondary to your fat malabsorption and your overall malabsorption in the intestine, where you'll have reduced absorption of vitamin D, which is a fat soluble vitamin, and you're going to have reduced absorption of calcium also. Because of that, there is increased risk of fractures in these patients, osteopenia, and kyphoscoliosis. So all these are very, very important things to note. Clear? So these are the clinical features. Then how will you diagnose? Investigations. Remember, first of all, how will you do a neonatal screening? It's a very important question for MLE exams. Whenever you know how to know about neonatal screening, how to go about neonatal screening. Because why it's important for MLE exams is because every single US child and United States child is screened for cystic fibrosis. India, none of the neonates are screened because there is no point in screening India. As I told you, it's very, very, very rare disease. How they do is typically do something called a heel prick test. This is a very common test, heel prick test, a single blood test which tests for almost every single inborn errors of metabolism in US. Very, very famous test there, heel prick test. In that they do a test called immunoreactive trypsinogen, whose levels will be increased if the patient is supposed to have a cystic fibrosis. Remember, this immunoreactive trypsinogen will not be secreted from the pancreas if you have a cystic fibrosis. So since it's not getting secreted, its levels in the blood will increase. Not secreted into the, into the duct, pancreatic duct, not into the blood. Secretion doesn't happen to the duct, so backflow, their levels in the blood will increase. So increased immunoreactive trypsinogen is a very, very important marker of cystic fibrosis. Further, you can confirm with other tests, but this is a very, very important basic screening test. Apart from that, you can do a DNA assay also. DNA assay can be performed either prenatally or even postnatally. Can be did prenatally or postnatally, but very commonly they do prenatally. Indication is when both the parents, both male parent as well as the female parent, are heterozygotes for cystic fibrosis gene, then their child can be did a prenatal screening via amniotic fluid analysis. That's why it's called amniocentesis, or you can do is a CVS, chorionic villus sampling. Anything you can do. So this is how you can do a prenatal, screening for a cystic fibrosis in a child whose both their parents are carriers or heterozygotes for cystic fibrosis gene. It's a known case. Postnatally also you can do in certain suspected patients. That is also indicated. Fine. So how will you confirm? These are the screening methods, and what is the diagnostic criteria for diagnosing cystic fibrosis? So number one, you will have typical clinical features of cystic fibrosis you might see in the patient. For example, a meconium ileus in the newborn. Plus, you should have evidence of cystic fibrosis transmembrane regulator dysfunction. How can you tell? The sweat chloride levels will be more than or equal to 60 millimoles per liter at least on 2 occasions. At least on 2 occasions, number one. Second, you can prove the CFTR gene mutation. I told you any one is enough. You can prove the CFTR gene mutations. Third one, you can prove that the patient is having abnormal nasal potential difference. This emerging as one of the very, very important tests. Suppose your sweat chloride and gene mutations are not giving a sufficient answer, a clear answer, then you can go for this nasal potential difference testing also. I told you why the sweat chloride is more, because CFTR is important for reabsorption of chloride as well as sodium. So since CFTR is defective, they cannot reabsorb the chloride, and more chloride tends to accumulate in the sweat in the skin. That's the idea. So how will you do this? The method where they perform the sweat chloride test is what we refer to as something called a quantitative pilocarpine iontophoresis. Pilocarpine iontophoresis. So this is supposed to be the gold standard for doing a sweat chloride test. Remember, the test can be performed only if the infant is more than 2 weeks of age and if the infant is more than 2 kg in weight. And again, it's a very important rule. This test can be performed only if the infant or neonate is more than 2 weeks of age and if the infant or neonate is more than 2 kg weight, because otherwise if you do in a very, very young age, in the first week or second day, third day itself, there's a lot of possibility that you will get an inaccurate result. To get more accuracy, this is the rule that you have to do for doing this sweat chloride test. Apart from that, you can do a CFTR gene mutations also. We have seen you can do prenatal as well as postnatal, both of which we have described. And finally, you have this abnormal nasal potential difference test. I told you this is done especially if your sweat chloride as well as DNA analysis is inconclusive. If inconclusive, clear? So in this condition only you can do this nasal potential difference test, or otherwise called as transmembrane nasal potential difference test also. Fine. Then these are the diagnostic criteria. Apart from that, other tests that you can perform is spirometry, which is going to show an obstructive lung disease pattern. And you can do also stool tests in order to confirm an exocrine pancreatic insufficiency, where typically we do a fecal elastase or 72-hour fecal fat, whatever you want you can do, 72-hour fecal fat or fecal elastase. All these tests are tests of malabsorption, especially due to pancreatic insufficiency. Clear? So these are some of the tests that you have to know. But apart from that, you need to definitely know this gene mutations. You need to definitely know about this sweat chloride test, and definitely this more than 60, very, very important. Apart from that, you have to know that nasal potential difference also. That test is also very, very important. Then we'll move on to the treatment of cystic fibrosis. Treatment wise, first you have to treat like how you treat a bronchiectasis. At the same time, you have to take out these thick secretions outside. That is why for pulmonary problems is the first priority, because they commonly die of respiratory failure only. That's why this becomes the first priority. Take the secretions out by giving mucolytics. One of the important mucolytics is 3% sodium chloride, hypertonic saline. Or you can use an enzyme called Dornase alpha. This can be given in nebulizations also. This is a recombinant deoxyribonuclease 1. So I can call this recombinant DNase 1. So called as Dornase alpha. Or you can use a N-acetylcysteine also. So these are some of the mucolytics that we use. But remember, this Dornase alpha is approved only for cystic fibrosis patients, not anyone else. Then you can give a bronchodilator, because this bronchodilator therapy, like salbutamol nebulizations, will cause more caliber of the bronchus, which means the secretions will come out easily, more because larger airways, more easier to come outside. Then like bronchiectasis, here also I can use a chest physiotherapy, just to take the secretions outward. And all are for bronchiectasis purpose only. And if the patient is having chronic sinusitis, especially of polypoidal type, you can try doing a intranasal glucocorticoids. In India, very commonly we use a trade name called Avamis nasal spray. So intranasal glucocorticoids also can be tried to reduce the symptoms of chronic sinusitis. Here we are only treating symptomatically. We are not curing the disease because it's genetic disease. Then suppose if the patient has gone for respiratory failure, which means respiratory insufficiency, you can try giving long-term oxygen therapy, LTOT. The indications of LTOT we have discussed already in COPD section itself. Then finally lung transplantation will be the last resort. Clear? Lung transplantation will be the final resort in these patients, because still if you have no option, nothing can be done. Lung transplantation will be the final say. But remember, if you have BCC, Burkholder Capacea complex, lung transplantation is contraindicated. Clear? Colonization with BCC is a contraindication for a lung transplantation. Next, you can do vaccination. Obviously, the two important known vaccines are pneumococcal and your influenza vaccine, both of which are important and reduce the risk of, at least to some extent, they reduce the risk of infections. And next thing, there's another drug called Povilizumab. You can use for infants within 24 months of age. You can use for infants within 24 months of age. This is a monoclonal antibody against respiratory syncytial virus. So it acts against respiratory syncytial virus, monoclonal antibody against respiratory syncytial virus, where in cystic fibrosis you can give for infants less than 24 months of age, less than 2 years of age. So that's called Povilizumab. And a lot of new drugs have come for cystic fibrosis patients. A very important new drug is Lumacaftor-Ivacaftor combination. Lumacaftor-Ivacaftor combination. And second one you have Tezacaftor-Ivacaftor combination. Lumacaftor-Ivacaftor and second one is Tezacaftor-Ivacaftor. We are living in an altogether new era, and these newer drugs are actually protein modulators. They modulate the CFTR protein. Typically, these drugs are more effective for respiratory disease than other diseases, but astonishingly, they are changing the structure of the proteins. They are protein modulators. Remember, Lumacaftor-Ivacaftor will be effective only for the characteristic 508 mutations. They will be characteristically effective only for this 508 mutations. They will be completely ineffective for other mutations. They will not be effective. I told you there are 2000 plus mutations, but the most common is the F508, this mutation. Usually they will be effective only for this mutation. They will not be effective for other mutations. Clear? So here the function of the Lumacaftor is to, I told you this in delta F508 mutations, F508 mutations, the cystic fibrosis transmembrane regulator proteins are synthesized, but it's not moved to the cell surface. So what this Lumacaftor will do is, Lumacaftor will help the CFTR to move to the cell surface. Lumocaptor will push this CFTR to the cell surface, and this ivacaftor will help the CFTR to open properly. Clear? So this lumocaptor will help the CFTR to channelize properly to the cell surface, and this ivacaftor will help the CFTR protein to open properly. So these are the functions of lumocaptor and ivacaftor. And tezacaftor and ivacaftor also we'll see. Tezacaftor and ivacaftor, it's effective for two common mutations. One is your famous F508 mutations, and it's also effective for G551D mutations. This is a very common mutation, but not common as F508. But this tezacaftor and ivacaftor is effective for both F508 and G551D mutations. Clear? Mechanism of action is very, very similar to that of lumocaptor and ivacaftor. There is no much difference in mechanism. Apart from that, treatment-wise, diet is very important. Diet in cystic fibrosis patient, you will increase the sodium chloride intake because they don't secrete it properly in many secretions. So increase the amount of sodium chloride. At least that increased concentration will make the secretions more, like containing sodium and chloride. And second thing, you have to give high energy feeds. That is to compensate for the malabsorption. High energy plus at the same time they will be needing more protein diet. At the same time they'll also be needing more nutrient based diet, because a lot of micro and macronutrients, especially vitamins, will be lost. They cannot absorb all this, so you have to supplement all this. Then probably you might be needing this pancreatic enzyme supplementation also, again which will be useful for malabsorption due to chronic pancreatic insufficiency. Then how you are going to manage the infections? In infants, usual pathogen will be Staphylococcus aureus, and typically we treat them with IV vancomycin, point number 1. Second, in adults, very commonly it will be either due to Pseudomonas aeruginosa or it will be a Burkholderia capacia complex. Pseudomonas aeruginosa you are going to treat with inhaled tobramycin, because I told you the anti-pseudomonal drugs. What are the anti-pseudomonal drugs? We discussed in pneumonia chapter. We are going to give my mnemonic called Campfire. In that you have this aminoglycosides that is very, very important. This is an anti-pseudomonal drug. Similarly, this tobramycin is also aminoglycoside only, which is coming in a nebulized fashion. So that's why this inhaled tobramycin is one of the important treatments for Pseudomonas colonization in patients with bronchiectasis, or especially in patients with cystic fibrosis in Western countries. Suppose if tobramycin treatment is not giving rise to any big improvement, suppose if there is poor response with tobramycin, then you can try IV antibiotics like ceftazidime or IV tobramycin, or even a meropenem, carbapenems. Because I told you C stands for carbapenems, M stands for monobactams, that is aztreonam, P stands for polypeptide antibiotics, that is colistin and polymyxin B, F stands for fluoroquinolones, IR stands for third and fourth generation cephalosporins, and E stands for extended spectrum penicillins. That is your piperacillin tazobactam, extended spectrum penicillins or anti-pseudomonal penicillins. So in that, the third generation here, what I told you is the third generation cephalosporin, that is ceftazidime, then aminoglycoside, that is tobramycin, and carbapenem, that is a meropenem here. So remaining, if you want to use piperacillin tazobactam, that also can be tried depending on the sensitivity results. And Burkholderia capacia complex, it's a real nightmare. It's very, very difficult to treat. It's not going to respond to many of the drugs. At least Pseudomonas is responding to this polypeptide antibiotics like colistin and polymyxin. But this Burkholderia capacia will not respond to colistin also. They are naturally resistant to this polypeptide, not only colistin, and polymyxin B also. They will not respond. They are naturally resistant to these drugs, this polypeptide antibiotics. But how you are going to treat? Typically what we try is this ceftazidime plus cotrimoxazole plus or minus we also tend to give minocycline or doxycycline. Mino or doxy. So this is the common regimen we follow. It's a very high resistance. You cannot treat only with ceftazidime because there's no single drug here. How do you always use in a combination because the percentage sensitivity varies. There may be 45-50% sensitivity to ceftazidime, 35-40% sensitivity to cotrimoxazole, 30-35% sensitivity to doxycycline. So you really doesn't know. And Mino works better than doxy for Burkholderia cariopsia. But anyway, it's a real nightmare. It's very difficult. Always use in combination. Very important drug is ceftazidime. Why I told this ceftazidime in the sense because one important point about this ceftazidime and Burkholderia cariopsia complex is that ceftazidime may show in vitro resistance. Like this Burkholderia cariopsia complex may show in vitro resistance to ceftazidime, which means in the culture plate it might show resistance, but most of the time it's proven that ceftazidime works very well, which means they have in vivo sensitivity. Inside the body they do have some effect on BCC. So always your regimen should contain ceftazidime for Burkholderia cariopsia complex as much as possible. This is our core ID principles, core ID data. So certain things you go with the culture, certain things you don't go with the cultures. Even if the culture show resistance to ceftazidime, many times I go with ceftazidime if the organism grown is Burkholderia cariopsia. Okay. And other drugs that can be effective to an extent is carbapenems. Carbapenems, especially meropenem. Remember, colistin will not work. Even though colistin works for almost every gram-negative bacteria because its action is on the lipopolysaccharide, it doesn't work here. Burkholderia cariopsia, Serratia, Proteus, 3 organisms you have to remember where colistin and polymyxin B cannot touch because they are intrinsically resistant to this polypeptide antibiotics. Then you can get aspergillus, typically ABPA. You're going to treat with itraconazole, or in very, very severe cases, you can even try a voriconazole. Then you have Stenotrophomonas maltophilia. This again another nightmare organism, very, very difficult to treat. Stenotrophomonas maltophilia, where typically we treat with cotrimoxazole. That is trimethoprim and sulfamethoxazole combination. Cotrimoxazole, clear? So these are the important things that you have to know before going into exam, because this Burkholderia cariopsia complex have been many times asked in exam how to treat. I will always prefer giving a ceftazidime. I mean, if your exam option contains ceftazidime, and that will be the best regimen. And apart from that, you can use these drugs also, which are also very effective for your Burkholderia cariopsia complex. Then these are the ways how you treat the patient with cystic fibrosis, and the most common cause of death in these patients will be type 2 respiratory failure. Respiratory failure, that will be the most common cause of death in these patients, and very commonly it will be due to infections that is causing respiratory failure. That will be the usual reason for death in these patients. Please be very, very clear about that. Respiratory failure is the most common cause of death. Average survival and the maximum survival known to humans in a patient who is living with cystic fibrosis is approximately 39 years with advanced care. Whatever advanced care you give, currently we cannot make the patient survive beyond 39-40 years. This is the maximum. If the patient's age is 40 plus, rule out cystic fibrosis from the diagnosis. Not possible. Even 35 plus, 30 plus itself, we sometimes rule out the diagnosis, but even though current advances keep the patient alive for a little bit more longer time, so you can give a cushion right now up to 40 years. So anything more than 40 years of age, don't keep cystic fibrosis as a diagnosis in your mind in exams. It's not possible, absolutely impossible. Clear? So these are the things I want to tell in cystic fibrosis. It's a very important question for MLE exams, very important topic for MLE exams, but as such in Indian exams right now the questions are reducing in the topic of cystic fibrosis. So it's your wish ultimately to read or not to read. But anyways, I've told whatever it's possible to tell. And very importantly, in exam sake, you need to remember that modern protein modulators, those drugs are very common areas you might be getting in exam. The tezacaftor, ivacaftor and lumocaftor, ivacaftor combination. Please at least remember that for exams and go. And how they work and what are the indications of these drugs, for which mutations they work. At least remember that. Okay. With this, we are completing the obstructive lung disease section. In the next section, let us move on to the pleural disorders part.